Welcome to AFSPA Talks, a production of the American Foreign Service Protective Association with Chief Operating Officer Kyle Longton. Be sure to subscribe to us on your favorite podcast channel. Enjoy the episode.
Hi, and welcome to another episode of AFSPA Talks. As always, I'm Kyle Longton, and with me is
Hannah Wolfart.
Hannah, today AFSPA talks healthy pregnancy. This has been a topic that comes up quite often in some questions that I get from members, as well as some of our quality measures that we look at for the whole plan. But one of those measures we've looked at is that for the past 2 years, the top reason a Foreign Service Benefit Plan member has been admitted to the hospital has been related to maternity. And that for the first half of 2021, maternity and newborn admissions make up 47.6% of all admissions, almost half of all admissions. And that's great. I think that's great, so that it's not people going in because they're sick, but maybe for delivery. But we've got a lot of programs out there that can help members, and we'll talk about some of those. But I'd like you to highlight, if you could, some of the details around our healthy pregnancy program that we offer to FSBP members.
Definitely, Kyle. So once a member enrolls in the Healthy Pregnancy Program, they receive a Healthy Pregnancy Handbook, Guide to a Healthy Pregnancy, a pregnancy wedge pillow, and a Ready, Set, Baby brochure. And after the baby is born, members will receive a What to Expect in the First Year book.
Excellent. Yeah, so many of us have been familiar with What to Expect When You're Expecting. It is the book and maybe even the movie that was out, I don't know, a decade ago now. But that first year, it's great to know what's how to prepare when baby's coming, but what do you do once baby's here? So that is great. And our programs to support members through pregnancy, the programs do not end once baby is born. We've got a number of programs, and we also have expertise available, and we're going to share some of that today. And I think that's a good segue to introduce our guest today, who is Dr. Joanne Armstrong. She's an MD and also has her master's in public health. And she is the Chief Medical Officer for Women's Health and Genomics at CVS Health. She's responsible for women's health and genomics policy, strategy, and clinical program design across all of CVS Health enterprise units. Dr. Armstrong has practiced clinical obstetrics and gynecology for more than 25 years. And she is board certified in obstetrics and gynecology and has an additional training in epidemiology and, as I mentioned before, public health. She's going to take us through the entire process from preparing for pregnancy, preparing for conception, what happens during pregnancy, some of the challenges that come along, as well as what to expect post-delivery. And I'm delighted to have her here. Dr. Joanne Armstrong, welcome to AFSPA Talks, and thank you for joining us today.
Thank you for inviting me. I'm looking forward to the discussion.
Well, we are delighted to have an expert with us to discuss healthy pregnancy and delivery. And just in that vein, I want to start out with sort of a broad question. Knowing that each person is different and each pregnancy is going to be different, can you share with us some common elements of a healthy pregnancy? What is the goal when we're looking at healthy pregnancy?
So great question. Healthy pregnancy actually begins before pregnancy. It really starts with the intention of every woman and family for what they want to do from a reproductive perspective. It's important to note that about half of the pregnancies in the U.S. are not planned, and by not planning, there's a lot that is lost. One of those things is just the timing of pregnancy, right? It's good to plan pregnancies when you're emotionally ready, financially ready, and importantly, physically and physiologically ready. So not planning misses that opportunity. The other thing that's important is pregnancies that come close together, that is not well spaced or not having optimal interconception spacing, can have some medical complications on their own. For example, babies can be smaller. Some women have increased rates of preterm birth. The other thing that's really important in planning pregnancy is women have, on average, about 10% of women have some chronic condition that they go into pregnancy with. And this period is the time to really optimize that. So, and some of these things actually can get worse because the physiology of pregnancy can make them worse. and so they need to be optimized beforehand. A few examples of that.
Yeah, that'd be great.
Yeah. So a few examples of that are women, for example, women with chronic hypertension. There's some medications that are dangerous to take during pregnancy because they can have effects on the development of the baby. So you would want to change those medications before you could become pregnant. For women who have chronic depression, for example, or some other behavioral health challenges, those medications also may not be, some of them may not be safe or better optimized in pregnancy. In the case of diabetes, where women have pre-gestational diabetes, very high levels of glucose. So in other words, diabetes that is not well managed has two important effects in pregnancy. One, it can increase the rate of miscarriage. And two, it can also influence the development of the fetus and result in birth defects. So preconceptionally is the time to really get diabetes under control. And then there are a number of conditions that are similar: weight management, smoking cessation, et cetera.
And so what steps, I mean, we've touched on it a little bit, but what role might a relationship with a primary care doctor or a regular relationship with an OBGYN play in optimizing oneself for in one situation for pregnancy?
So one of the things that I really advocated with my own patients is in every visit, just to ask this question. I think clinicians should ask it, and women should also be thinking about it. What are my reproductive intentions this year? Would I like to become pregnant? Whether you're going in for a sinus infection or a regular GYN exam, it's just a question that we should ask ourselves. And are we moving in the direction of health? If the answer, well, we should always move in the direction of health. But if we are particularly interested in planning pregnancy, we should have this in our head that many of the challenges that we face take a long time to sort of get control of, whether it's smoking cessation or completing vaccine series or having a past history of an abnormal pap smear evaluated. So I advocate that patients should think, what are my intentions this year, and am I really taking care of my intentions? And clinicians should do the same thing. And then, of course, depending on the answer to that, one either, right, thinks about what contraception or family planning might look like if you're not interested in becoming pregnant. And if one is interested in becoming pregnant, it's a question of when would I like to become pregnant? And what steps should I take between sort of now and when I would ideally like to become pregnant? So that's really the starting point. It's a good sort of mental exercise for us to do all the time anyway.
And once somebody thinks that they're pregnant, they have that first positive home test, what is the next step they should take? They've got the test in hand. Is it a call to the doctor? Is it a visit? What is the next step?
So the next step really is to pause, congratulate yourself, think about, just take these moments, right, of sort of joy and expectation, visualizing, what's next. I think that's really important because we often sort of get on this track where it's like you just start right away thinking about, I've got 100 things to do. And it's really important to pause, center yourself in your own pregnancy and ask, what is it that I want? Think about that. So some of the things, the choices that can come up are things like, well, what type of pregnancy care model am I interested in? Am I interested in midwifery-based care, for example? Am I not interested in that? Do I have a good relationship with my OBGYN? Is this somebody who hears me, who has enough time for me, not a judgment? Some practices are just really busy, or they're structured in a way that there are just a lot of physicians and you're not sure that you have a relationship with anybody in the practice. So pause, ask yourself, what is it? What are my intentions here? And do some work to sort of think about what model of care you want and what that provider would look like. And there are lots of ways to find information about that, right? Dr. Wikipedia is one, right? But close friends, and ask questions, like really pragmatic questions. How often do I see the same doctor? Does this practice, what are the hours? Are they flexible enough that they fit in my schedule? Was there time spent to sort of listen to me, to hear me and my voice and what I want? So there are a number of pragmatic things just to think through about what type of birth one wants. Was there something that happened in the last pregnancy that you really want to reflect on and say, really wasn't the model for me? I felt not listened to. I felt rushed. There was something about the hospital environment, the way I and my baby were treated together, for example. I'm not saying this to be judgmental in some way. I just want to elevate the issue that we have choices, often have choices. And by taking a few moments to sort of think, what is this experience that I want to have? Obviously, it must be safe, but is it really centered on me and my choices? Does it fit the type of life that I have? Is there any flexibility in that schedule? And do I have other past experiences that either I've had or perhaps my friends have had that might inform how I want to think about this? So that's the first step.
Absolutely. And I think I appreciate you saying take a moment, pause, and savor that news, because sometimes we move right past that moment and miss it, and we're making an appointment for the first prenatal visit or choosing a doctor if we're in a new place, all those things. So I appreciate you inserting that in there, and then going on to the practical matters and seeking input from your friends and others, and reflecting on past experiences. So as we're thinking about the goal of a healthy pregnancy, a healthy delivery, and so forth, there are some complications that can arise during pregnancy. And you've talked about ways to sort of optimize health going into pregnancy and preparing for pregnancy. And you touched on some of the possible complications that can arise. But I'm wondering if you can go a bit more in depth on some of the most common complications that arise during pregnancies and how they are identified and addressed.
Yes, for sure. And I would say that, complications arise in pregnancy. And as I noted, complications could have arisen in a prior pregnancy that have implications for this pregnancy. Mm-hmm. Or women, of course, we come in with our own chronic conditions, et cetera. So if this is not the first pregnancy for patients, it's important, and they're not going to the same physician, it's important to get your medical records from the prior pregnancy so that can be shared with your current obstetrician. It really helps the physician really understand, perhaps if there was a preterm birth, what was actually behind that, a complication, an urgent cesarean delivery. There's nothing like having the exact records, maybe the lab values, to understand what this is, what happened. So as we enter into prenatal care, the first visit that women have, it's really busy, right? There's a review of your past history. So again, coming in with a coordinated, list of your medical problems, the medications that you might be on, the records that you had from a past pregnancy will really help organize that information and actually give you a little more time with the physician to open up the space to talk about these other things that are not necessarily medical. The first visit also goes over family and genetic risk. These are particularly important to have these conversations with a physician and determine whether there's certain genetic testing that's recommended for you or genetic counseling. So again, bringing that in. I'll also make a plug that November is the time that families, at least in the U.S., families gather around the Thanksgiving table. It's multi-generational. Families, it's our time to ask about genetic conditions that might run through families that actually may have implications in, for your own personal health and for your pregnancy. So then once we sort of have an understanding of women, pregnant people coming in, sort of their past history, past obstetrical history, then we sort of start walking through pregnancy and some of the problems that can happen in pregnancy. So some of the more common ones are what's called gestational diabetes, and that is diabetes that happens because of the physiology of pregnancy. Okay, It's different than having it pre-gestational, and sometimes it's hard to unwind whether someone who presents with diabetes actually had it before their pregnancy or during pregnancy. But upwards of as many as 10% of pregnant women will develop diabetes, what's called gestational diabetes. Another really important problem in pregnancy is called preeclampsia. And preeclampsia is this really weird form of hypertension that happens only in pregnant women, and it accelerates very quickly, and the treatment for it is delivery. It tends to happen in the later part of pregnancy. It occurs in about 4 to 8% of women. It is a major cause of preterm birth, low birth weight, and severe complications for mom and for the baby as well. We know what the risk factors are for that, although half of the women don't have risk factors. What's really important about preeclampsia that I really want to make a strong plug for is there is a very simple intervention in the form of low-dose aspirin that can lower the rate of this, really bad disease by as much as 30%.
Wow.
And and what's really important about it is, and low-dose aspirin is recommended for women who have what are called major risk factors, which include a past history of preeclampsia. So bring your records in, chronic hypertension, diabetes, connective tissue disorders, but lupus and things like that. But it's also, a risk factor is also defined as women who have what are called 2 moderate risk factors. And those are much more common. Advanced maternal age, that proud group that I was a member of as well. So women greater than 35 when they have their child, women having a first baby, women who are obese, women who have particular stress, environmental stress, or even stress that's related to race. Women, African-American women, poor women, it's all under the bucket of stress. But women with 2 of those moderate risk factors are also at risk. And very often we don't appreciate, that we're in those groups, and there's literature that backs that up. So important here is to sort of understand this disease, talk to your physician about it. Low-dose aspirin starts early in pregnancy, as early as 12 weeks, and it continues all the way through. So a really important, simple, and very safe intervention to lower the rate of an important disease significantly. But it requires, a discussion and awareness of this and a conversation with your physician. The other thing that I would like, so we've talked about diabetes, we've talked about chronic hypertension and this preeclampsia, this weird form. I want to, because we are living in the age of COVID, I'd like to just take a moment, if it's okay, to talk about COVID and pregnancy.
Please.
Okay. So pregnancy, the being pregnant itself is a high-risk group for severe complications of COVID. The reason for that is because the physiology of pregnancy, having basically a big uterus like a watermelon in your abdomen makes it hard for us to breathe, right? Our lung excursion is decreased. And pregnancy is also a kind of a relatively immunocompromised state. When you think about it, this beautiful thing that is the physiology of birth, we have to kind of suppress a little bit of our immune system to grow a baby that's not actually antigenically, immunologically like us. And so that makes pregnant women more susceptible to severe respiratory infections, particularly, so COVID and flu. So COVID and flu both are recommended for vaccine during pregnancy. Only about 30% of women are vaccinated in pregnancy. Half of those come in as vaccinated preconceptionally. So again, the importance of preconception care and the importance of COVID is that half of our pregnancies are not planned. It is a risk factor for bad things to happen. And those bad things that can happen to pregnant women are they have much higher rates of hospitalization, the requirement for ICU admissions, requirement for intubation and respiratory support, and maternal death. And their babies also have a higher rate of adverse problems in pregnancy related to preterm birth, low birth weight infants, et cetera. So really important to get COVID vaccinated. It is recommended by every professional college that is devoted to the safety and the health of pregnant moms and their babies. Pediatricians, recommend this as well, and it is safe. There's now a lot of emerging data that it is safe in pregnancy.
And I so appreciate that, because there were questions. I think I've heard people in my own life say, "Oh, I don't know if it's safe to while I'm trying to conceive or while I'm pregnant," and I so appreciate having you here as an expert and confirming the data that's out there and sharing it that it is safe. And I think there are also other vaccines that you would recommend from a previous conversation we've had for those who are pregnant, and I think also those who would be around a newborn. What are there's two particular vaccines that we talked about before, the flu and the Tdap. Is that right?
That's right. So flu, or seasonal flu virus, is a problem in pregnant women for the same reasons I just talked about, the physiology of pregnancy. So pregnant women are a high risk group for requiring hospitalization due to flu. So all pregnant women are recommended to get the flu vaccine during flu season. So, beginning in October. It is safe. It's been, that vaccine recommendation has been in place for many, many years in the U.S. Millions of women are vaccinated every year for flu, and very safely. On average, though, only about 50% of women get vaccinated for flu. And some of the reasons for that are OBGYNs generally are not vaccinators in the way, family docs are, for example. So if you're, here for people who are listening to this, excuse me, ask about flu vaccine. If your physician does not vaccinate, there are lots of places to go. CVS Health, the pharmacy counters are there, the minute clinics. There are flu clinics, vaccine clinics, all over the place. It's really important and very safe. The second vaccine recommendation is called Tdap, and it's for the P in Tdap is for pertussis, which is whooping cough. And whooping cough is another important infection that in pregnant women, but particularly their infants, it's one of the leading causes of viral hospitalizations for newborns. And we vaccinate moms because by vaccinating mom, you provide passive protection to babies. And this is true for flu, for pertussis, and the data is emerging that it is also true for COVID. So how does this work? A baby's immune system is not fully formed at birth. It is, it develops over the next months. And so babies are susceptible to respiratory infections when they are born. So vaccinating mom, actually those antibodies that the mom antibodies are what protect us against invading viruses. They get passed through the placenta to the mom, to the baby rather, and then it protects the baby during this critical period of time where they are too young to be vaccinated, but it gives them a bubble of protection around them. So for these three vaccines, very important in pregnant women.
Fantastic. And I'll just note for our listeners, all of those vaccines covered at 100% by Foreign Service Benefit Plan, as well as other federal plans. And as Dr. Armstrong noted, available at pharmacy counters, at minute clinics, and with your primary care physician likely. So please seek those out. Now, Dr. Armstrong, before we get to discussion of delivery and postpartum care, which I do want to make sure we talk about, are there some things that carry stigma and are difficult to discuss when it comes to pregnancy?
Great question. There are a number of conditions that are stigmatized during pregnancy, for sure, and then other things more broadly in women's life. One of them is miscarriage. Miscarriage is common. It occurs in between 10 and 20% of all pregnancies. And most of what underlies miscarriage is not anything that's wrong with a person or a pregnancy. You didn't do anything wrong. But when you think about what has to happen genetically and physiologically, to develop a pregnancy and have it implant and grow, it's a little bit like gardening. I'm a avid gardener, and I plant, 10 pea plants. I get 7. I can change the soil. I can do lots of things, but just sort of, to get everything to align properly, sometimes it doesn't work. The challenge for women in pregnancy is it's such a private moment to miscarry. Sometimes people around you don't know that you're pregnant. Sometimes you've already shared the news with joyfulness, and it's very hard to wind that back. There's often a feeling of guilt that, I did something wrong, or there's something wrong with me or with us. That's not true. And then the other thing that's really hard is you go out in the world and you see moms and babies and baby carriages and things that are sold to us in stores, and the reminders are just everywhere. So what's important for miscarriage is the recognition that it is common, although sad, that generally it doesn't foretell anything wrong. There are ways to evaluate for causes of what we call a recurrent miscarriage, so which is defined as 2 or more. So it's really important to bring that up both preconceptionally. So again, a plug to think about pregnancy planning and some of the tests that can be done to plan for that. And then from an emotional and behavioral health perspective, to share generally when we have burdens, sharing them helps lift them up off our shoulders. So it's important to find trusted people, that care for you, that you care for, that you can talk about it. And if you need more than just a friend, to really rely on behavioral health resources, that's really important.
And that's something we focused a lot on during this podcast this year. Are there other behavioral health issues that can arise or pose particular challenges during pregnancy?
Yes. So depression is certainly a common problem among all of us. Depression and anxiety. We're living in a very challenging world right now. Particularly, COVID has really amplified that due to the feelings of isolation, economic challenges that all of us are living through, educational challenges, where kids learning on Zoom. It's just been a mess. And so, the numbers bear out that the rates of depression and anxiety have increased. That's even above the baseline. It is an area that is stigmatized during pregnancy, but particularly in the postpartum period. There is a phenomenon of postpartum blues, which is just a sadness that happens after delivery. Some of it is related to the hormonal physiology of pregnancy.
Sure.
Some of these hormones just kind of washing away. But the other thing is that's really not appreciated because, the broad world messaging is everything is wonderful, and it's all
you should be happy.
Unicorns, and
yeah,
you should be happy. But these little 7-pound things are enormous challenges. Babies, they don't eat, first of all, they don't come with a textbook. And most pregnancies are, most of us are first-time parents. We all have to be first-time parents once. And we just don't know how to run these little things. They eat, they're up all night. We don't have any skill sets to handle it. Many of us, the way we live now, we don't have extended families and friends around us. Mm-hmm. So it is extremely challenging. And there's questions about our competence. We are exhausted, and it's just really hard. So that sort of describes, I would say, the anxiety almost all parents face. Anxiety can cross into depression, where you really are not, you're really having challenges meeting the sort of the daily needs of life. There are certainly a lot of resources that are available for women. I would say the first thing, this is as it relates to stigma, same thing, raise your hand and ask for help. If somebody says, hey, I'll make you some meals, accept it. You don't have to be a superhero. If somebody can come in and just take the baby for a few hours so that you can sort of take a shower or do something that just, sit on a park bench, go to the store and look at the vegetable aisle, anything that brings you a sense of normalcy, structure, calm, say yes and ask, and ask again. If you're more than that, you're really having a challenge kind of getting out of bed, maybe bonding, understanding, taking care of the needs of yourself or your baby, ask for help, call your physician. It is really important that in the pregnancy delivery model, physicians, obstetricians now ask frequently about behavioral health and postpartum depression. It should not be something that is stigmatized, in 2021.
So I'm so grateful for you covering sort of the broad range of issues that can arise and encouraging people to rely on their communities, whether it's faith communities, neighborhoods, family, whatever is available to them. And yes, let somebody come in and just hold the baby, because you can just walk away, have a break, and so important. And I'll just note that FSBP offers a number of programs to support people facing any of these issues, including nurse care manager support, a healthy pregnancy program, Able To, which is designed to help with major life events like the birth of a child, My Strength, and more. And I'll have some more information on that at the bottom of the podcast. But Dr. Armstrong, you touched on this before, and I just want to come back to it quickly as we're talking about delivery and postpartum care, as well as the prenatal experience. You mentioned sort of you touched on a holistic approach and getting information up front, providing information to your doctor. Is there anything else besides providing those medical records, making sure you've got the good relationship? Anything else you would share, maybe perhaps something more about how to form and then communicate your birth plan?
Yeah. So, as we said, pregnancy is not just something that happens to you. It's something that you actually have a say and sort of what the design of that would look like. It's really important. So it really starts, as I said, with a pause to just ask, what does it actually mean for me? And then being kind of proactive about the elements that you would like that to be. It starts with who your provider is, a provider setting. Is that a midwife-based model? Is it a large group practice model? There are midwives that happen that in many practices they integrate midwives and obstetricians. There are, in many cases, birthing centers that are actually within the hospital itself. And that would be more sort of, I would say, patient-centered kind of environment. So a birth plan starts with sort of what this looks like. It addresses a few things. So in the prenatal setting, it sort of helps you think through what those visits are like, who you're meeting with, perhaps what your intentions are with respect to, say, genetic testing. Do you want that or not? What does that mean? As you get closer to delivery, it also starts involving, the plan starts early, but what are your desires with respect to how that actual delivery takes place? So for women who are having first-time births, presumably the goal of everybody is to have the goal certainly for everybody is to have a safe birth and a vaginal delivery. So you can talk to, do some reading, talk to your doctor about what can you do to help support a vaginal delivery. And some of that is actually related to the timing of your delivery, meaning does your physician routinely induce everybody at 39 weeks? For example, a term delivery is 39 weeks. If you were to go in and if your doctor's practice, the office practice is to induce everybody at 39 weeks, the challenge with that is it increases the rate of cesarean delivery, because not everybody is inducible or ready to deliver at 39 weeks. Is there, what does the call structure look like on the weekends? Are you going to, is the physician who's going to be there if you go into labor on Saturday or deep in the night on Tuesday? Who is that physician there? Who is that person taking care of you? Have they seen your birth plan? Do they know actually something about you? You can start thinking about what type of anesthesia, I might want or not want in pregnancy and in the delivery, and talk to the practice about what their attitude is with respect to that. Some practices have pregnancy classes or group prenatal care. If that's interesting to you, ask about it. A practice may not have group prenatal care, but they may have sort of support groups for pregnant patients where they take patients that are more or less at the same gestational age, so that groups learn together. It's a very fun way. Not all centers do this, but it's an interesting and a fun way to meet other patients that are mostly around your gestational age And, and you can exchange information about what pregnancy is like. Many of these groups continue all the way through delivery and into early childhood. So ask about that. Also ask about, lactation services and breastfeeding intention, right? Is the group doing anything particular to support that? Or is it sort of passive and left to whatever happens in the delivery room? And sometimes that's not the recipe for sustained breastfeeding, which is really important. It helps build the immune system for a baby, decreases, ear infections, for example, increases the rate of bonding and closeness of families. It's not for everybody, but if it is for you, you want to make sure that the structure of how the support is delivered actually supports you.
That's great. And I think, as you mentioned, thinking toward and planning for whether it's breastfeeding or if you family might be thinking about formula and so forth. I think that's a good gateway for us to talk a little bit about postpartum care then for following delivery. What recommendations do you have for people following delivery?
So a few things. One, there is an increasing appreciation that pregnancy is a window into future health for women. 10 years ago, 15 years ago, we just thought, you deliver, that stage of life is over and now you're back. And, once you sort of have kids and raise them, you realize how ridiculous that is. Pregnancy is this, it's not just an event. It is in many cases, it's a pivotal event in our lives, both sort of, from an emotional perspective, from a family perspective, but also physiologically, from a physiologic perspective, our bodies change. And some of the things that happen in pregnancy actually have very important medical implications for the rest of our lives. For example, we talked before about preeclampsia and diabetes. Gestational diabetes. So preeclampsia, again, this very weird form of high blood pressure, actually increases our lifetime risk of chronic hypertension by about 4-fold, and our lifetime risk of major cardiovascular events, stroke, heart attack, about 2-fold. It is actually a major risk factor. It carries with us as a risk factor for cardiovascular health for the rest of our lives. So we should think about that. It's important that after we deliver, that is not just forgotten and put in a drawer, because that 30-year-old will become 40 or a 40-year-old, right? And when someone says, do you have cardiovascular risk factors? I myself have preeclampsia. The answer is yes, I do. So I am particularly careful about what my blood pressure is. I pay attention to my cholesterol because I know I carry that risk factor with me personally. I also want to make a plug for making sure that after you deliver, you have a medical home, meaning you're cared for either by your obstetrician gynecologist if they manage medical problems, or if not, to a family medicine physician, internal medicine physician that can sort of carry the baton of chronic disease and prevention of chronic disease going forward. The second example would be gestational diabetes. Because pregnant women generally are young, for many women, it's the first time that they enter the medical system. So when you are diagnosed with diabetes in pregnancy, you do ask the question, was this actually pre-gestational diabetes? Did it happen before you were pregnant? We just happened to capture it because we test for it in pregnancy. That's really important. And in fact, a fair percentage of people who get diagnosed with gestational, meaning pregnancy-related diabetes, actually, when they're not pregnant, will continue to carry the diagnosis of diabetes. And that has, of course, all the implication of diabetes in our lives. So post-delivery, pregnancy just doesn't end and we're done with it. All the new diagnoses that we might have accumulated carry forward. Our chronic disease management carries forward, and we need to think about what continuous care looks like. So the plug is, it's really important to keep appointments for postpartum visits. Many women don't, and particularly women who are having second babies and third babies because they think I've done this before, but it is an important missed opportunity. And then the other really important opportunity, it goes back to where we started our conversation, about intention, and to give your baby every good thing. It's really good to space out pregnancies so that women have a chance to recover physiologically from a nutrition point of view, et cetera. And also that we get to plan our next child so that we are in the place that we want to be, from a medical perspective, financial perspective, employment, job, career perspective, all of those filters. So talking about contraception, family planning while you are pregnant, it generally will occur sometime in the third trimester of pregnancy. And the reason why it's brought up there is because there are some forms of contraception that can be provided while you're actually in the hospital. So for example, if you wanted an IUD, that can be provided right after you deliver. So it's important to get that started early. And if you don't do that, to make sure that you have a contraception plan coming out of pregnancy, again, if your intention is not to become pregnant. So those are just some of the things to think about, of course, as it relates to behavioral health, depression, reoptimizing medications are really important after we deliver. Same thing with chronic hypertension. As I said, we might change some medications while you're pregnant that we want to change back again once you are not pregnant. And then the other thing that's important for women to remember, again, preconception care is important, but there are some things that happen during pregnancy that we just can't address optimally when you are pregnant. So for example, women who have abnormal pap smears and might need biopsies of their cervix, we can't do it during pregnancy because of it's too complicated to do. Mm-hmm. Those women need to come back immediately postpartum, right, where we're able to fully evaluate these diseases.
Good. Yeah. And the ongoing importance, as you noted, of that regular relationship with a provider. Dr. Armstrong, this has been a fantastic conversation, and I appreciate that you've covered everything from planning and for family planning and preconception planning and optimizing health to postpartum care following delivery. Before we wrap up, is there anything else that maybe we've missed or that you would like to add?
There's one thing we missed, and it's when we were talking about sort of the importance of, what are the big problems in pregnancy. I realize I'm remiss in sort of talking about preterm birth, because it's really important. It's very common. About 11% of births are preterm. They vary by a lot of risk factors, cultural backgrounds, racial backgrounds, social, environmental backgrounds. But preterm birth is defined as a delivery. It's actually less than 39 weeks is the age that is considered full term. Less than 37 weeks is associated with some medical complications for babies. What's really important with preterm birth, it is one of the leading causes of kind of lifetime morbidity and challenges for babies. So it's something that carries forward. Some causes of preterm birth are preventable, and that includes things like assessing for infections that may occur, something called a weakened cervix that may be treated with basically a stitch or a cerclage in the cervix. It's important for women who have a preterm birth. It's particularly important to follow up after you deliver, to really do a deep dive with the physician about what caused it, preeclampsia, for example, and to think, what can I do to optimize this in the preconception period for it to not happen again? And if I have optimized everything there, for example, smoking increases the risk of preterm birth, let's address that, right? Once we've optimized everything we can do preconceptually, it's very important that we come in early for care to see if there are things that we can do very early in pregnancy that can lower the risk. So just want to make sure everybody hears that, because it's a common problem, and there are things that we can do to lower the risk or even eliminate the risk.
Absolutely. Thank you very much. And we're seeing some increase in that, including increases in C-section, cesarean births among our own population. So thank you for covering that and spending so much time, talking with us today and covering so many different subjects. So Dr. Joanne Armstrong of CVS Health, thank you again.
You're welcome. It's my pleasure.
FSBP members have access to the plan's Healthy Pregnancy Program at no cost. To learn more and enroll in the program, please call 855-282-6344. Additional information about the pregnancy program, Able to coaching programs, and more is available in the plan brochure and on our website at afspa.org/FSBP. Thanks for joining us for this episode of AFSPA Talks, a production of the American Foreign Service Protective Association. Please subscribe, rate, and review the show, and tell your friends about it. We welcome your feedback on LinkedIn, Facebook, and Instagram. Look for @AFSPA Cares. All information offered in this podcast is meant to be educational. Comments offered by the hosts or guests are not intended as medical advice. Please direct questions about your personal health needs to a provider. Should there be any discrepancy between information offered in this podcast and official plan documents for the Foreign Service Benefit Plan or other products offered by AFSPA, the policy provisions will prevail. Special thanks as always to Hannah Wolfhart for producing, editing, and mixing this episode. We'll see you next time.